Hello everyone, welcome to the Yorkshire Dental Suite YouTube channel, and today I'm going to show you our first video of a surgical procedure for removal of impacted lower wisdom tooth. I'm going to start off by showing you the x-ray, explaining to you the degree of impaction and also the close proximity of the wisdom tooth to the ID nerve. And then after that I'm going to take you step by step through the surgical procedure with a voiceover. So to start with, as you can see, this OBG radiograph showing you the impacted, mesioangular impacted lower left 8 and also mesioangular impacted lower right 8. If you look at the lower left 8, you can see this tooth has got two roots that are quite close to the ID canal. And as you can see, this is the ID canal. It looks like tram lines coming down from the base of the skull along the inside of the mandible. So the tooth is mesioangular impacted against the 7, and if you look at the other side, it's very similar. But what you can also see here that the roots are fused. So fused roots containing bone in between them, and again it's even closer to the ID canal. So the next video I will show you how to take out the lower left 8 surgically, step by step, with voiceover. Hopefully you'll find it easy enough for you to do it yourself. See you next time. So step 1 is achieving a good local anesthesia. So I use xylocaine to numb up the ID nerve. As you can see, I'm using my thumb to feel for landmark, which is the coronoid notch in this case, and I approach the anatomical side from the opposite side between 4 and 5 and about 1 centimeter above the occlusal plane, hitting the point is bisecting my thumb fingernail. So I feel for the bone, I withdraw a little bit, inject slowly for the ID nerve, and then I withdraw my needle about halfway for the lingual nerve. So that's for the ID nerve and the lingual nerve. Then the next step is to use another local anesthetic for the long buccal nerve. You can either do this by injecting distal to the tooth to be extracted, or along the external oblique ridge. Few drops will be more than enough, and then I go back to give another ID block. I go slightly higher. This is a good trick for you to learn. If you fail your anesthesia, go back again and go slightly higher, and then inject slowly again for the ID nerve. Okay, so I've given 2 local anesthetic using xylocaine for the ID nerve and the lingual nerve. I'm giving another injection again just to show you how high you can go in case you fail to numb up the numb up the ID nerve. Now raising the flap, as you can see, I'm using number 15 blade, starting by making a distal relieving incision. You have to stretch the tissue to cut through the tissue neatly, and to make sure that you cut at right angle to the bone, and make sure it's full thickness mucoperiosteal flap. When you cut, it's always nicer, and also it makes life easy to stretch the tissue as much as you can. Once you've cut your incision, you retract the flap using the periosteal elevator. If you cut a nice flap, if you cut a nice incision down to bone, then the flap should raise nice and easy with no effort at all. Now you can see it's full thickness mucoperiosteal flap. Now I'm gonna make a buccal gutter. Here I use number size 50 millimeter round burr or rose head burr with plenty of irrigation to make a buccal gutter, buccal to the tooth to be extracted. In this case, it's the lower left wisdom tooth. Most important thing when you cut, especially when you go around the distal buccal cusp of the tooth, it's better to start from the distal side and come toward you, just in case you slip and you may cause damage to the lingual nerve, which is a very superficial, just below the lingual mucosa. So always cut from distal buccal toward you, i.e. mesial. So plenty of irrigation. Make sure you cut to the correct depth. My aim is to again go down to the cemental enamel junction so I can see it. I see where the bifurcation is, and like you can see now, I'm dividing the tooth longitudinally to section the roots. So the other advantage of using the round burr is you can see where the tip is all the time. This makes it slightly safer than using the fisher burr. So I'm making sure that I cut through all the enamel and dentin to make sure the breaking of the tooth and splitting of the tooth is less traumatic. Now you can see I'm using the luxator to section the roots. So I've just loosened the distal part or the distal root, picking it up, and now I'm going to go back and loosen the mesial part of the tooth using the same elevator. So if you make a nice cut, then elevation of the tooth should be nice and easy, making sure I've removed all the fragments. Now tidying up and making sure nothing has been left behind. Once you're happy, then you close the wound. I normally use 3/0 Vicryl Rapide. Using a resorbable stitch means you don't have to see the patient again to have the stitches taken out. I use Vicryl Rapide as opposed to Vicryl because it resorbs within a week or 10 days, whereas the normal Vicryl takes sometimes good 3 to 4 weeks to go away. Obviously, the longer it stays in the patient mouth, the more discomfort it causes. So I use interrupted stitch. The first suture should be distal to the 7 to make sure there's no pocketing distal to the tooth. Sometimes you can get away with one stitch. Usually I place at least 2 stitches. So 3 throws just to make sure the stitch is stable. The problem with Vicryl as opposed to monocryl, for example, it does sometimes can be unpredictable and the knot may lose its strength earlier than expected. So another stitch along the external oblique ridge, again interrupted. So I use 2 throws to start with, and then 1 throw in the opposite direction, and the last one will be opposite to the last one, but only 1 throw. So make sure the stitches are stable. As you can see, the first stitch I placed has become loose, so I've taken it out. I'm going to do another stitch. This stitch is quite important. So again, simple interrupted stitch, distal to the 7. So 2 throws, pick it up from the tip, make sure it's tight, and then another one in the opposite direction, and always a third one just to be in the safe side. Okay, so that's your suturing, and then once suturing is finished, you clean up and ask the patient to bite on a damp gauze for a good few minutes. Once you achieve hemostasis, give the patient post-operative instructions, not only verbally but in writing as well. I hope you enjoyed it. See you next time.